In the previous video, we were discussing about the general principle involved in management of poisoning, where we came across with the 6 principles. We are discussed about stabilization, and we were discussing about evaluation in the previous videos. Now, these evaluation parameters, various parameters were enlisted. Already we are covered with hypothermia, hyperthermia, as well as acid-base disorder. Today, let us continue the discussion with a list of agents which can cause convulsion, agitation, movement disorder, and electrolyte disturbances, and how to manage it. As about the convulsion and anti-convulsant agents, if people are aware, just here I will be enlisting various agents in higher dose which can cause convulsion and how to manage the situation. So there are several drugs and poison which can cause convulsion. Suppose improper treatment or mismanagement if happened with a patient, which can lead to status epilepticus in a person. Sometimes it may turn as life-threatening condition also. So here is a list of agents which can cause convulsions. The drug toxicity includes amphetamine, anticholinergics, antidepressants, antihistamines, caffeine, camphor, carbon monoxide, chlorinated hydrocarbons, cholinergics, and cocaine, cyanide, heavy metals, isoniazids, organophosphates, strychnine, sympathomimetics, and xanthine. Even sometimes the drug withdrawal may also precipitate convulsion, like barbiturates, benzodiazepines, ethanol, methaquinone, so then opioids. So during these conditions, the treatment should be started. Initially, supportive care treatment should be started. Administration of oxygen by nasal cannula or mask is preferable. So then position of the patient head for optimal airway patency should be maintained, and we should establish intravenous line. So begin the drug therapy with benzodiazepines. Lorazepam 0.1 mg per kg can be given at a rate of 2 mg per minute, or diazepam can be given 0.2 mg per kg at the rate of 5 mg per minute IV route. If status persists, then we can go for administering phenytoin 15 to 20 mg per kg at 50 mg per minute. So now with adult 1 mg per kg per minute can be administered. So then coming with the phenytoin, this phenytoin is incompatible with glucose containing solution. So the IV should be purged with normal saline before phenytoin infusion. So this precaution should be taken. Let us move on to the status epilepticus. Suppose it still persists, administer 20 mg per kg phenobarbital in IV route at 100 mg per minute. If these measures also fails, so then we can start with general anesthetics dose of phenobarbital, then pentobarbital or thiopentone, halethone can be given. So in such cases, breathing difficulties could be observed. Then ventilator assistance is required. Even in order to regulate the blood pressure, vasopressor become mandatory during the treatment with such agents. Then simultaneously monitoring of ECG, then hydration level of the body, electrolyte balance, then hypoglycemia, cerebral edema should be checked simultaneously. So now let us see the common drug used to treat status epilepticus. We have different doses and the drug. Adult intravenous dose milligram per kg, diazepam 0.15 to 0.25 mg per kg, lorazepam 0.1 mg per kg, phenytoin it is 15 mg per kg to 20 milligram per kg. Phenobarbital it is 20 milligram per kg. Pediatric IV dose milligram per kg. Diazepam 0.1 to 1. Lorazepam 0.05 to 0.5. Phenytoin 20 and phenobarbital 20 milligram per kg. So even in the pediatric rectal dose is also preferable. 0.5 milligram per kg diazepam can be used, and the maximum IV rate milligram per kg of each drug we can observe. Diazepam it is 5, lorazepam it is 2, phenytoin 50, phenobarbital 100 milligram per kg. The maximum IV rate can be given. So coming with the duration of action in hours, diazepam 0.25 to 0.5, lorazepam it's more than 12 to 24 hours, phenytoin it's 24 hours, whereas phenobarbital it is more than 48 hours. Then coming with side effects, common CNS depression, respiratory depression and hypotension and cardiac arrhythmias can be observed with these drugs. Diazepam can cause CNS depression in 10 to 30 minutes, but lorazepam it takes several hours to show the response, but phenytoin have not shown such effect. But phenobarbital in several days it may cause some CNS depression responses. Coming to the respiratory depression, occasionally diazepam causes lorazepam, but phenytoin infrequently it can cause respiratory depression, and phenobarbital occasionally it causes respiratory depression. Then coming with the hypertension, diazepam and lorazepam infrequently it can precipitate hypertension, but phenytoin occasionally, but phenobarbital infrequently it can. Coming with the cardiac arrhythmias, only phenytoin occasionally it may precipitate cardiac arrhythmias in the people. That's why monitoring parameters are mentioned in the previous slides. The next monitoring parameter it can be observed, that is the agitation. This agitation is a mixture of anxiety or even nervous excitement can be observed. So many drugs and poison will be associated with increase in aggression in the patient. Sometimes this not treated, it may progress towards the psychosis and the patient may turn towards a violent behavior. So this is morely seen with the people who have pre-existing mental disorder, or if he is having a hypoglycemia, hypoxia, head injury, anemia or vitamin deficiency. So they have more chances of going to the violent behavior. So then it followed delirium, which is nothing but the acute psychotic episodes, which is characterized by disorientation, irritational fear, hyper excitability, hallucination and violence can be observed. So many of the drug which causes agitation and psychosis, so during a toxicity doses it may causes, or sometimes sudden withdrawal of the drug can also cause agitation and psychosis. Example of the drug which causes agitation and psychosis in the toxic dose includes amphetamines, anticholinergics, antidepressants, benzodiazepines, cannabis, cocaine, corticosteroid, atropine, digitalis, ethanol, then hallucinogens. When drug stoppage or withdrawal of barbiturates, ethanol and opiates can also cause this agitation and psychosis. So they are coming with the next parameter, that is the dementia. So here nothing but a more gradual decline in the mental processes can be observed with the people. Confusion and memory loss can be seen with the people. It's organic in nature due to degenerative diseases. Some of the dementia status can be observed due to drugs on chronic exposure. Many times these elder populations are very much vulnerable to this dementia condition. So many times the drug induced dementia are reversible in nature. Once you stop the drug administration, further the patient may come out from the dementia. So here is a list of drugs that can cause dementia like symptoms in long-term uses, which includes antidepressants, antihistamines, anti-Parkinson agent, anti-anxiety medications, cardiovascular drugs, anticonvulsants, corticosteroids, then narcotic agents, sedatives. So upon stoppage or re-challenging, so there may be chances of getting recovery of the dementia which is induced by the drug on long-term use. Then coming with the management, this delirium is managed by administration of chlorpromazine, diazepam, haloperidol. So we should use these drugs with caution, so as these drugs exhibit sedation as a side effect. Then coming with the management of violent patient in casualty, we will be using tranquilization technique here. We will be using mild tranquilizing agent like we will call it as antipsychotic agent, which can reduce the violent behavior of a person. So here is a list of types of violent behavior and what are the therapeutical measures can be given. Schizophrenia is a type of violent behavior. It may include any type of other psychosis. Lorazepam 2 to 4 mg intramuscular route combined with haloperidol 5 mg intramuscular route can be administered. If extreme agitation observed, lorazepam 2 to 4 mg intramuscular route every hour it can be given. If personality disorder observed, lorazepam 2 mg orally every 1 to 2 hours or 2 to 4 mg intramuscular every 1 to 2 hours can be given. Sudden withdrawal of alcohol can also cause some violent behavior in a person. In such situation, chlordiazepoxide 25 to 50 mg orally or as required, or lorazepam 2 mg orally can be given. Or cocaine and amphetamine toxicity can also induce violent behavior. Diazepam 10 mg every 8 to 6 hours orally or intramuscular can be given. Even phencyclidine toxicity, it's also a highly abused agent like diazepam 10 to 30 mg orally or lorazepam 2 to 4 mg or haloperidol 5 mg intramuscular route can be administered. This is how we can manage violent behavior in a person by giving various tranquilizing agents. Then coming with the other abnormalities, which includes movement disorders. These movement disorders may happen because of exposure of drugs and toxins. So wide varieties of movement disorders will be observing because of the overdose of a drug. So it may range between full-blown Parkinson disease to isolated tremors. So many of the victim agents, we can say it as phenothiazines and major tranquilizers. Let us see one by one movement disorder. The first is the drug-induced myopathies. So this result from direct toxic effect. It may be the administration, that's a local injection of the drug to a muscle, like more diffuse when drug is taken systemically. So even repeated injection of antibiotics or some drug addicts people also. So they will be injecting drug in the muscle. So by severe muscle fibrosis can be observed in such patient. Like other clofibrate and aminocaproic acid can cause acute necrosis, myopathy with myoglobinuria, and even renal failure can be observed. This is a drug-induced myopathies. Let us see the example of drugs which can induce toxic myopathy. Drugs like succinylcholine, halothane, corticosteroids, chloroquine, dipencilamine, alcohol, phenotine, thiazide diuretics, amphotericin, procainamide, penicillin, lipid-lowering drugs. So they can cause toxic myopathies upon prolonged exposure or in toxic doses. Even many of the environmental factors, when the body got exposed with some of the things, like it may cause myopathies, which includes like exposure of body to silica and even some food substances and additives which got adulterated with some rapeseed oils. Even some of the medical devices like silicone implants, so they may also cause myopathies. So next, continuation with the muscle problems, like akathisia can be observed. So akathisia is nothing but an extreme restlessness with constant movement, and muscular quivering can be observed in such condition. Involuntary movements can be seen with the voluntary muscles. So this can be observed because of tricyclic antidepressants, monoamine oxidase inhibitors, fluoxetine, lithium, buspirone and levodopa, which can cause dystonia manifestations, which can be observed in the person, like facial grimnancy can be seen by observing the face. In this diagram we will come to know, like expression will be entirely changed with the person, or it may come across with torticollis condition. So then here, coming with this situation, we can observe the failure of the neck muscle, such that the tilting of the head towards the neck can be observed. Certain drugs like phenothiazine, butyrophenols, metoclopramide, tricyclic antidepressants, phenytoin and chloroquine can cause these muscle complications. Then even chorea can be observed. This is nothing but involuntary writhing movement of the limb can be observed because of anticonvulsants like phenytoin, anabolic steroids, amphetamines, levodopa, and sometimes cimetidine, ethanol and cocaine can also cause this chorea condition. Phenothiazine and metoclopramide can also cause tardive dyskinesia, which can be observed in the face jaw. It will become very difficult to open the jaws. Then coming with the other muscle complications like myasthenic crisis can be seen. The sudden onset of severe muscle weakness can be observed because of aminoglycosides, polymyxin, penicillamine, tetracycline, quinidine, lignocaine, quinine, curare and succinylcholine can cause this myasthenic crisis. Then some agents, it causes fasciculations. These are nothing but contraction of muscle fibers within, and individual motor units will get affected, whereby twitching can be observed in the affected muscles. Some of the agents in toxic doses which can cause fasciculations includes amphetamine, barium salts, black widow, spider bite, caffeine, camphor, cholergenic in excess, cocaine, fluorides, hypoglycemics, lead, lithium, manganese, mercury, nicotine, phencyclidine, quaternary ammonium compounds, scorpion sting, shellfish poisoning and strychnine. Then coming with the tremors, drug-induced tremors. So now let us see the types of tremors and what are the causes. Resting, so more pronounced at resting time can be seen, same as for drug-induced Parkinsonism. The same causes can cause these tremors. Then even sometimes like postural, most pronounced in and outstretched hands, like beta agonist, phenytoin, valproic acid, tricyclics, lithium, arsenic, alcohol withdrawal, amphetamines, caffeines, cocaine, theophylline and carbon monoxide. When kinetic time tremors can be observed, most pronounced with movements like chronic alcoholism, mercury, lithium, acute sedative, hypnotic, and even overdoses. Then chorioid, like a repetitive breathing movement of the hands can be observed. Same as for choreal. Also anticholinergic amphetamine, bromocriptine and manganese. So dystonic tremors can be observed. So muscle group may undergo spastic condition like drug, neuroleptics, antiemetics, cocaine and chloroquine can cause these tremors. Okay, coming with the conclusion of the movement disorders. Most of the movement disorder are induced by the drugs or sometimes with the overdose or with toxins also, and it depends on the duration of exposure of such agents to the body. Even many times like withdrawal of many substances can also helps to recover from the situation. If the management of the respective overdose must be instituted wherever applicable by giving some drug or either by withdrawing the drug. So here is a glance of drug-induced movement disorders. Many drugs can cause, and let us see about the movement disorder. Like drugs, amoxicillin, it causes Parkinson, amphetamines, hyperkinetic movements, antihistaminics, orofacial dystonia, myoclonic jerking, butyrophenones, Parkinson, orofacial dystonias, opiostonosis. This opiostotonus is a condition of form of muscle which causes backward arching of the head, neck and spine. This is a diagram which represents opiostotonus. So where we can observe backward movement of the neck because of contraction of the body. Then even caffeine can cause myoclonic jerking, carbamazepine, orofacial dystonias, carbon monoxide can cause Parkinson, monoamine oxidase inhibitor, rigidity. Then even it can cause opiostotonus situation. Then even nicotine causes falsic fasciculation. So this is nothing but brief spontaneous contraction which can affect the small muscle fibers also. Organophosphate can cause falsic fasciculations. Pethidine which causes tremor, muscle jerking. Phencyclidine, it can cause generalized rigidity. Then tremors, orofacial dystonias and twitching can be observed. This phenothiazine causes orofacial and other dystonias. Phenytoin causes chorioheterosis. Then strychnine, which causes rigidity. Then even tremors can be observed. Also it causes opiostotonus. This tremors is a condition where it becomes difficult to open the jaws. Tightening of jaws can be observed. So in the next video, I will be talking about the electrolyte disturbances.